Thank you for those great presentations. There's so much exciting research going on right here in our own state of Florida. Questions for the presenters? And I think there's some microphones floating around.
Yeah, my husband's a researcher, so he's given me a list, but there's one in particular that he's been talking about. It's some sort of ultra mega variation of B12 injections they're using in Japan. Anyone heard or have any idea what that is that I'm talking about? Do you know the name of it? Okay, and then the second question is, what is your input on the diaphragmatic defibrillator? Is anyone using that or having any? Am I not supposed to be asking these questions?
We'll do number 2 first.
Let's do
okay,
number 2
sure.
first. Thank you.
So the diaphragm pacer story is one where we still have one person living with it who got it implanted many years ago. It is unclear if that person has ALS, but the idea behind diaphragm pacers is that you could stimulate the phrenic nerve where it inserts into the diaphragm and therefore keep the muscle pumping longer. Unfortunately, it doesn't work. When the nerve is lost, the muscle degenerates and there's nothing there to stimulate. We can't keep the muscle around, so until we have those kind of stimulating factors that keep muscle cells around, it isn't going to work. The trials that were done showed some harm, and so we have kind of abandoned that.
So are you saying that the muscle itself will degenerate faster because it's not being used of its own volition?
If there's no nerve cells going to a muscle, the muscle shrinks away. It's very visible. Most people with ALS knows what that looks like, and that would happen. That happens to the diaphragm muscle. And again, if there's no muscle that you stimulate, the way you're actually stimulating the muscle is that you're stimulating the nerve ending. You're not directly stimulating the muscle, you're stimulating the nerve. And when that is lost, there's nothing there to stimulate. ALS is a nerve disease, and we know that since the first researchers who started looking at this thought it was a muscle disease, and that's back in the 1840s. And again, they called it progressive muscular atrophy then, but a few decades
So
later.
after the diaphragmatic muscle does its dying process, that means that it can no longer be stimulated by any artificial means. Is that what you're saying?
Yeah, so the problem is not in the muscle, the problem is in the nerve, and when the nerve is lost, the muscle will go away.
Do people use it for comfort or for before the nerves are bad? Direct muscle stimulation. That's what we were just discussing. Yeah, thank you very much. I appreciate it.
And the next question is about B12, and I think this is a point where me and Dr. Locatelli are we read the same literature and have a little bit different take, but I'm gonna let him answer his impression.
And of course, I'm right and he's wrong, so. Methylcobalamin, there's different forms of vitamin B12. So there's published 2 studies in Japan that led to the Japanese government to approve the use of methylcobalamin as a treatment for ALS in Japan. Nowhere else in the world yet. So that's the data out there. It's a pharmaceutical grade methylcobalamin in Japan. So the studies that led for the approval, the way we read them is, we can take different interpretations. I've just seen also something not published. I went to Australia, and it's the Pacific Consortium, so the Japanese researchers presented a 1.5-year follow-up in the second study, and they continue to show benefit with the use of methylcobalamin. So now they have a problem because there's this shortage of methylcobalamin in Japan. To clarify, the dose is not the supplemental dose that you can have by mouth, 1 to 5 milligrams a day by mouth. This is 25 or 50 milligrams intramuscular twice a week. So this is what is called in the paper the ultra-high dose. So is this dose in which in Japan is approved for the treatment. So in our practice and the Kathy J. Hasman ALS Center, and even before when this came about, I decided, because patients were asking for it, and the data has some validity, and other neurologists have said there's something is there. It's more than we see in many other things. So it's not guaranteed, but at least a government and many researchers think that this is an effective treatment. So in my practice, I recommend it. I said, I think you should try because it's safe. In my practice, we already have over 80 patients that have been receiving it for several years, and they do urinate pink in color. Is visible. Is not. They do get injection in the muscle, but there's no really other side effect that we can report over. I've been doing it for 5 years now. In the study that I mentioned earlier today, what my endpoint is trying to see if I can show that it works, this generic B12 that we can prescribe here in compound pharmacy. So we are looking into that. It seems my first analysis seems that it is working, but I need to do better matching controls trying to actually certify that and publish it. So for the time being, I'm looking to see if I can prove that in our practice works. So I'm looking at, okay, take it. There's a lot of data, in my opinion, and others that this will work, but I have to follow up and trying to prove it with the generic. So I'm planning to add other things. For example, it's been mentioned the neurofilament. If the vitamin B12 will drop, the neurofilament will support it, so on and so forth. So in summary, in my opinion, it's safe. It costs $100 to $200 a month. If the patient is willing to take that chance and spend that money, then I think there's enough to say that it's likely to be effective. How much, in what patients, there's all the details we don't know. So in my practice, I do prescribe it, monitor it, and trying to answer the question, does it really work, this generic, or does it not? So it's, I think I'm trying to be conservative in what I say, but I truly, personally think that it works. So, but thinking and feeling is one thing, science is something else. So, sorry for the long answer.
I want to take a quick minute to welcome Dr. Weimer to our panel. Dr. Weimer, could I ask you to introduce yourself, please?
Sure. Sorry, I was the late one coming in, still covering the hospital. But thank you. Yeah, Jim Weimer at the University of Florida in Gainesville, as well as the Gainesville VA, directing both clinics.
So as I mentioned, we had some questions that were submitted in advance, so I'd like to share some of those with the panel at this time. So there's a question about progression. Somebody wrote and said that they've noticed they have periods of improvement. For example, there's a person who seems to be able to move their mouth and swallow better than they did last year. Why does progression seem to be reversing?
We like to talk.
I'll jump in. Okay. The thing about it's such an individual disease, and that should be one of the take-homes that you saw where we're looking at following this disease. And we all can describe the patients that we followed who showed gradual progression and then leveled off for a period of time. And this is one of the great mysteries that we're working on, that you're hearing from all of this, whether it's All ALS, Target ALS, the Natural History Consortium that I work with. We're all doing the same thing, is trying to identify, are there differences between these patients? What makes the difference between the patients? And then can we, from what we've learned from that, apply that to others to find out? It's a great question because people come to us. We've all experienced, they come to us and they say, this has improved or this has leveled off, and why? I think that's a real question, and you heard the hesitancy in everybody because we all have that same question, and we're trying to, that's where research is active and where it has shifted to try and really address that.
I want to comment. There's a study from Dr. Bedlack and the PROACT database, and he gave a nice piece of data there. It's 30% of patients may not have any progression over 6 months. So 1 out of 3 might not change every 3 months, and 20% might not change over a year. So this is, a number of people is not progressive for several months a year. And it's likely during that stability, as Jim was mentioning, that stability that we can see some improvement in certain aspects. So I think this is something that we all have seen in a visit, that people don't change and get a little bit better, and then it changes.
And I would, since I also like to talk, so we see, you lose nerve cells, but you regrow them. So particularly the distal end of them, the ones going back to the muscles, always try to repair. And sometimes you might be winning. Sometimes things might actually be kind of keeping up. And we see that, I think, particularly in the pre-symptomatics as they're converting, that there's often this time when we're starting with things are developing, where there's a lot of, where we're very uncertain about if ALS really started or if it hasn't. And again, where things do kind of pendulate a bit. It can happen later, and there's drugs too. The Nuedexta, the dextromethorphan quinidine, does sometimes help speech and swallowing to the point that people can tell a difference. I think that's...
Might even be 12.
We have a couple of questions about medications, and especially for people who are newly diagnosed. It wasn't that long ago that the only option out there was Rileytec or Riluzole, and now there is Radicava and Nuedexta and Qalsody and the supplement question. So how would you advise a newly diagnosed person with ALS to kind of look at the landscape of medications? Is every person going to have their own individual conversation with their neurologist, of course, but is there something they can do to kind of prepare themselves for that conversation?
I can try to answer that. So we often describe ALS as one of the most heterogeneous diseases on Earth, where one person's ALS is not the same as another person's ALS. And so we really take an individual approach to everyone, and that includes prognosis and how you're expecting them to respond to medications. So the short answer is it really does require a good relationship with a neuromuscular neurologist. It's a process. There's no quick 20-minute video you can watch and understand how and what to do with this diagnosis. So my personal approach is to really form almost like a friendship with the patient and just to kind of work through it. And it can be very emotional, and it's very individual, the medications we choose. And so the answer is it's a person-by-person approach. And there are certain tools that are helpful for like supplements, like ALS Untangled, Richard Bedlack, who described these cases of reversals that we're all kind of mentioning. That's a really useful tool for supplements, where it summarizes kind of data, safety, things like that. But always best to go to your individual neurologist to ask your individual questions.
Okay, and I have a couple more medication questions. I'm going to kind of go through those rapid fire. Do statins seem to negatively affect ALS? And if so, how does that happen?
They do not. And I think the final answer to that was a good Danish study that came out this spring. There was definitely a lot of concern about this when statins became popular some 25 years ago. But I think that question has been put to rest with definitively a no.
Okay.
Now, some people don't tolerate statins anyway, and that could be whether or not you have ALS or not, so it's not right for everyone.
That also brings up a very important question that comes out of it, because we're working with a group that's putting together a paper about how ALS patients are still humans. And when we say, I've got, or your primary care says you've got ALS, you have to stop this, this, and this, you still are at risk for heart disease. You still have hypertension. You still have these problems. And avoiding those treatments because you're afraid they'll impact the disease, that's where that personalized discussion with your neurologist is important, because you still need all of the treatment that you had as if you didn't have ALS.
Good point, Dr. Weimer. And thank you for mentioning ALS Untangled, too. Someone had submitted a question about Deanna's protocol, and I know that's one of the reviews that ALS Untangled did. So please take a look at alsuntangled.org for more information on that. We actually got a question about if GLP-1 drugs might work in the treatment of ALS. I guess that class of drugs is in the news right now.
Are several of us part of the study? I don't know, are you guys part of the study?
I think these are like the Ozempic, I think,
Yeah,
right, GLP-1
there's a
drugs.
study that's sort of going on because of the exact opposite that the concern is, because if you look at how those drugs work, you lose weight by losing protein. And so the thought is exactly the opposite, but that question, there's a study out there that we're trying to get geared up with the group the Columbia's leading the study, and they've got several centers sort of helping them out to review and look at that. But so I think the question is very much out, but that's my concern, is that it can actually worsen the disease.
And Dr. Weimer, a follow-up question for anybody else on the panel. We had a question about how many calories should you take in a day, or how much protein should you take in a day?
Me? Go for it.
Sure. So this is also a totally individualized thing, which I'm sure is a frustrating answer. We can't just give you like an answer that fits for everybody. But the reality is that how many calories you need depends on, what gender you are, how old you are, how active you are. And so, oftentimes I have to, determine, nutritional goals for a patient. And there's good resources for me to do that, but it's not even just a quick calculation that I can do. It's, a spreadsheet developed by a nutritionist, and that accounts for a patient with ALS's activity. And so the long and short of it is that it's an individualized thing, and you should be working with your neurology team or a dietitian to help set those goals.
Gonna be hard to stop me. So there's one of the things about how much calories is what is your appetite. So there's information that we know that the hypothalamus is affected in this condition. So some patients lose their appetite. So all these principles are key that you actually look and measure, because your appetite is not going to be there. It's not only more difficult to chew or feed yourself, but also sometimes the appetite goes away. There's some cases in the opposite. They become, they eat too much. It's also a misconnection with the same center. So appetite can be totally misleading. So working and trying to follow numbers is essentially, particularly if you're losing weight, it's not that you don't want to, you lost your appetite, or nothing tastes right. So definitely working with your team.
And the rest of the panel may disagree, but I do tell my patients, good nutrition is absolutely as important as the medications that we're giving you. And we know that weight loss can definitely be a risk factor for shortened life expectancy and for the acceleration of muscle decline.
Okay, should we see if there's any more questions out in the audience? And then I've got more that were submitted in advance, so we can kind of flip back and forth. Anybody have a question? I think we have one up here. We have a mic coming here. Thanks.
This morning I talked about depression, anxiety, and mental health more of as a response to having ALS. Is there work on the effect of having these kinds of conditions and the thinking of them as brain diseases, depression, anxiety, and so on, and whether they contribute to the onset or progression of ALS?
I don't think I can answer that entire question because I'm not sure about how it might affect, like the objective data of how it might affect progression or onset. But there's no question that mood is a huge part of the management of ALS. We have a psychologist in our multidisciplinary clinic, and she has a really incredible impact on the health, well-being of our patients, and not just patients, but the family members. So there's no question about the importance of mood. There's a whole other topic which we could go into about emotional lability, which is not necessarily mood per se, but we do of course see pseudobulbar affect in ALS, which is something a little bit different. But I can't answer that entire question.
I think I'm thinking more in terms of the impact of stress hormones or the hypothalamic pituitary axis and how that affects brain function and disease.
So I'm not an expert on this literature, but some studies that we did, including the ALS Cosmos studies, where we looked at different types of stressor as risk factor for developing ALS, didn't seem to show any clear effects there. I know there's been many other projects done, but again, that Cosmos study, I think, is the best study regarding different types of stressors from psychological, environmental, and more somatic things that has been done, and it didn't show any clear connections there. But it is complicated to measure stress, and stress is a very broad concept that means different things and well, can mean different things.
One thing is simple and clear to me in the patients is you have to ask for the history of depression prior to ALS. So if somebody has had depression or anxiety with magnitude before the diagnosis, ALS is not going to make it go away. It's going to continue. It's going to exacerbate it. It's a pre-existing condition. It's like having other things. Then if you never had depression and you develop ALS, these are the questions whether the stressors, and I think in that, I like to see it in phases, not as one thing. And when somebody's diagnosed, there's a lot of fear initially. People fear everything. Then there's one that they lose hope. And then there it looks like everybody's depressed because, there's no cure, we don't know what to do, so on and so forth. Then they come out. They come out in a phase that hope is coming back. People get more energy. And then they get to a fourth, which I've seen some people here already with a lot of energy. It's the fourth phase, which is, I love it, which is the one in which they become ambassadors of the condition. They want to give back to the community. They want to participate in studies. They want to be in meetings like this. They want to help other people with ALS. So I see a second phase could be kind of assessed as depression, but then they come out and there's a lot of energy that the trauma of the diagnosis actually makes them more resilient, not to be depressed and actually be ambassadors with a tremendous amount of energy. So if it's pre-existing, it's one thing, then you have to see in what phase they are. And actually, as you see, antidepressants don't work quickly. So in these patients, usually, I don't see antidepressants being effective. And there's so many other things that can confuse the diagnosis, like apathy, or I don't feel comfortable going outside in the heat, and I don't feel doing X, Y, and Z. People may read that they are depressed, but other confounding factors can be there.
Question over here in the back, and then we're going to, sorry, we have over here first, yeah. They were waiting, sorry.
Yeah, I had a question on checking the neurofilament light chain. Is it more preferred through the spinal fluid or the blood? I've had it done both ways. Is one more accurate?
No, they're pretty much equivalent. So for example, the Valor study for Calcity, the serum NFL is the one that is reported.
Okay, and then I'm just going to take a quick question that was submitted in advance, and then we'll go back to the floor. So I'm not going to call these hot topics. They're more popular topics. We had a couple of questions about microbiome, about cannabis or cannabidoid type of therapies, and stem cells. Where is the landscape on those three potential treatment modalities? We'll start with microbiome, if somebody can comment on that.
I think these are all, you guys probably know as much or more than I do. These are sort of bedlack questions, both of those. But we all know that all of our patients are asking for fecal transplants, so that's a bedlack question. Nobody laughed. You know, the data on the microbiome gets back to what we were asking about protein and diet and all of that, that we know that plays a role. If we do a very carefully controlled SOD mouse study with varied diets where it's a controlled environment and everything except the diet is changed, we can show it has a huge impact on the microbiome. We can show that the diet has a huge impact on the disease. So we know these play a role. The problem is when you come to the human test, it just all falls apart. And I don't know if you guys have seen some data that points towards it. There's data that says it plays a role. There's data that's saying it can help. And I think that's, as a clinician, that's the difficulty I have. The one thing we consistently know about all of that is gut health is important. And, you know, keeping well hydrated is going to be important. Maintaining the caloric needs, working with your nutritionist. These are the key things that we know for certain that I think we all focus on for this while we're waiting for more research that has been going on for 10, 15, 20 years. It really needs some controlled studies that, again, BEDLAC is doing to address all of those. I don't know if you guys have any other insight into it, but.
I mean, I think I agree. There's animal data that suggests a relative importance of the microbiome, but the human data is really lacking. And I would be surprised if it's a major player, but certainly managing, as you suggested, is the thing to do for now. I think the other, guess we have the other two hot topics here, and again, of them, I think the cell therapy is the one that's the most exciting. I mean, there is that holy grail of cell therapy with actual motor neuron regeneration that sort of hovers somewhere in the future. That's still science fiction. That's not what we're trying to do with our current cell therapies. But if we could do that, then we would reverse ALS. So that's super exciting, but there's still a lot more basic science that need to be done before we can start attempting to regrow nerve cells in people, and current cell therapies aren't doing that. So they're could still maybe be useful, but it is very far from that holy grail, what we really want with cell therapy. So.
And I think maybe helpful to express the perspective, my perspective of kind of a concern about the cell-based therapies, the stem cells. I don't really understand how that might work. So I think some of the models that are being used is you collect, bone marrow stem cells, you grow them, and you manipulate them, and you sit in the back, and you put them potentially in the intrathecal space. We know that the ALS, the problem with ALS is in kind of the deeper, non-superficial cortical areas of the brain, so like the upper motor neuron and the lower motor neuron. I think my concern, and if this is solved somehow, I think stem cells could be very helpful. My concern is that the stem cells are not penetrating deep enough into the brain just by injecting them into your spinal column. So that's my hesitation. Although I do understand the hope that's paired with these therapies, and I hope that is solved.
My comment on this topic, and I did it already 2 or 3 years in a row with the stem cells, and I'm really sorry about something that's really happened nowadays. Get into the news, on your phone, on television, on someplace, and there's a big announcement. It can be from here, it can be typically from Israel, from another country, another place, saying this is going to be the cure. And then when you look, okay, that therapy is not really available. The problem with that is other places like these clinics, health clinics around Miami and other places in the state will claim now that these reports are true now, and they can do it for you. And then, it's somewhere. You can read it in the internet. Somebody put a press release. These other people had a video here, and somebody received the therapy, now is walking, and then you go and put $5, $10, $50,000 and receive some stem cell done somewhere. So they take your money. There's no science in there. There's no science. I mean, we see the challenges stated here. So be very careful about these therapies. You know, talk to your doctors, and probably want some family members maybe that can tell you that those therapies and those thousands of dollars you might be able to invest for a very low chance might not be the science you want to have.
And again, we're all scientists and we like the numbers, but of all the anecdotes, the patients I've seen have gone and paid for something like this, I have not seen anybody who had any benefit. And I think I could pass that question down the road just to kind of see if anybody has seen anything.
Unfortunately, I haven't seen any treatments like this that have been effective. And what I usually counsel my patients is that if you're going to look into stem cell therapy, I would recommend getting it done in a, academic medical center-based clinical trial. You absolutely shouldn't be paying for it. Anything that you're spending your money on is probably not going to be effective. And quite honestly, ALS is an expensive disease, and there's other things that you're going to need more.
Agree. I have to echo that. I've had patients travel really far and pay a lot of money, and without any difference in outcome. And it's a concern that people are trying to take advantage. So we definitely go to an academic institution for it.
I do agree with my colleagues that I never seen any patient benefited from that.
Powerful statements. Cannabis or the related type of therapies, any comments on those for either symptom management or treatment option?
Which one?
Cannabinoid.
Oh. Marijuana.
Go ahead.
I'm in favor. I think it's pretty harmless. I have seen people, benefit from it in some way. Maybe it increases your appetite. It's probably best not to overdo it. I've had patients I've had to kind of talk to their spouse, say, hey, this really got to cut back on the marijuana. But I do think that there's probably some benefit there, not from like a disease-modifying perspective, but certainly from a symptom management. I think it's potentially effective.
Yeah, I've seen it help with sleeping and cramping and pain and mood and appetite, but I'm not aware of any data that suggests that it slows disease progression.
And I want to add to that, some of those cannabis which increase the appetite might help the patients in a different way.
There's a good Italian study saying that symptoms, particularly cramps and things of that nature, do help. It's not the smoke marijuana, usually comes in the form of gummies. And I don't prescribe it. I don't know if anybody here, usually it's through these other clinics or alternative sources. I've seen that for a period of time is beneficial. The condition is a progressive condition, so it's not good for all the time. So cramps will diminish in its own, so people will use it for a while, and they don't. Some people kind of enjoy and relax because they kind of sleep. Other people really dislike it because they may mind altering doses and things. So again, I think we said enough. It's individualized. This might be good for some patients to take as a symptomatic approach. Other people will not like it at all. And probably, I think we all agree, they are fairly safe. They do not reduce the respiratory drive, which is what we feel in many of the medications. So this marijuana doesn't do that. So I think in that sense, it's safe, but it does have some negatives too. But in overall, it's a safe and it's worth a try if there are symptoms that you want to try.
But one of the things you have to keep in mind with it is it's still a pharmaceutical. We can call it natural all we want, whether we're talking high-dose B12, whether we're talking CBD, whether we're talking any of these, they're still pharmaceuticals that have drug-to-drug interactions that you need to be honest with your physicians about what you're using, and they need to talk and going over. So I make sure everybody knows that when they're trying it.
And one should take advantage of that it's a legal option in Florida and use the legal pathway.
All right, thank you for that. We'll go back to the floor. I think there's a question in the front row.
Yes. Good afternoon, panel. It's nice to put a face to the names. I'm talking on behalf of my father. We were actually at University of Miami earlier this week. Dr. Carberry, we saw your medical partner, Gustavo Almeida, and we were very interested on like what your recommendations are or your professional opinion when it comes to getting part of your stem cell research that I believe you're a part of with Neogenesis.
I'm not, but I do think Dr. Locatelli is. What is that? It's a neurone, I think he's referring to. Neuron?
Neogenesis, I believe it was called.
It's a stem cell.
So Neurogenesis as a company?
I believe so, yes.
Yeah, it's a different company. It just relocated to actually just to South Florida. They're in very early stages of that. It's also, they have a method to harvest autologous bone marrow, process it, expand it, modify it, and then re-inject it. But it's in the very early stages of developing. There's no product yet. They had not brought that in here. So it's a new company bringing the same concept of the other stem cells, but also bringing the concept of cell therapies overall. But it's not, again, those are things that have been advertised, but not really primed to do that. So it seems to be a good company very early on in the conversations for developing.
Is there any way to be part of that? Or is there any like, for my father to be part of that? Or is that just like internal with the company?
So,
When something happened and we actually have, there's a protocol with approvals and IRB and everything else, exactly like Jessica was saying, if there's a path in which it's going to be paid by the company that will be measuring neurofilaments and efficacy, then they will be available. At the moment, there's none of that right now. But when it comes available, sure.
So two great resources to find clinical trial information would be clinicaltrials.gov, and then you can search and then you can filter by recruiting or recruiting soon. And then also the Northeastern ALS Consortium, or NEALS, NEALS.org, has a search for a trial feature. And so that way you can kind of pare down into like what's available, where is it at, is it practical? And both of those websites will have contact information for a research coordinator who you can contact, and they would be able to look at your father's information specifically and let you know if he's eligible for those trials, when they expect to begin enrollment, that type of thing.
Okay. You said NEALS dot...
NEALS.org.
.org. Thank you so much. I appreciate it.
And there's another resource called I Am ALS, or ALS Signal. That's also very good. But I think it's a good point for me to highlight that obviously one university, one site can't have all the clinical trials. There's just too many. That's why we are collaborative like this. So if we can't do something, or we don't have the resources or bandwidth to host something, then we'll if you have an interest in something, we'll refer you to our colleagues here sitting at the table. So that's why it's so helpful to have these meetings, these discussions, and just be aware that just because we don't have something doesn't mean that we think it's a bad idea. We'll just potentially don't have the bandwidth for it.
I want to make a comment. I just learned this. What you guys mentioned on the sites that we currently use, but even for us, it's very confusing to know what study, and then when your family member yourself have certain features, you go like, which one is good for me? It's very confusing. What is moving now is the AI is trying to come to rescue us. There's one company and that is having a little of an AI, so people will put their information and it's going to come out with what works for this. There's another group, not-for-profit, Everything ALS, which are really working on a program trying to, once you put the information, the AI will go to these sites and see what's available and trying to match the two. So AI might help us in the near future to understand the specific features or your family member or you as a patient, and then give you options, because it's truly, those are the things we all do, trying to do that, but it's, and then we go, okay, for this patient, what is the specific trial? So we hope to clarify what is good for you with a little help from AI. I think that's one of the things AI will help us tremendously.
So it's interesting you mentioned AI. That's another question that was submitted in advance, is what do you see as the impact of AI on identifying a good treatment or a cure down the road?
I can talk the whole hour on this, but so AI has a lot of negatives as well. There's a lot of risk on where you put the information and where does AI take that information. And then AI has so many levels. For example, in MRI, AI programs can kind of help to read and measure things. So it is helping researchers to do standardized measurements. So in pathology and other imaging, things are specific AI programs. In terms of trying to do data analysis, sort of the same thing. But remember, AI has a mind in its own. So sometimes it will create something new, which can be really nice and new, but it can be nice, new, and wrong. So we still have to really work very much into understanding what AI is telling us, and then also make sure that the AI is going to move into environments that are protected in the way that privacy information, genetic information, or imaging information is still protected, because there's other consequences with that. But there's movement into actually have these programs in protected environments, so questions can be asked about how to move forward with this. So the AI is going to come and make huge positive advances. The scientific community still into make sure we don't do something really wrong because we misuse it. Again, it can give you a new and wrong idea. It might be great, but you have to still collaborate with the AI. It's just directly AI without us for now is not the way to go yet.
I would say the first thing that I've really been impressed with that helps people I know is the AI-generated voices. You may have seen some patients who have lost their voice, who have had their voice recreated by AI, and even if you know them, it can sound almost exactly like them. And I think that's the first thing I've seen that really works. I'm excited about it.
Do we have any other questions on the floor? If not, I can. Okay. I don't want to let you all get away without talking about genetic testing and genetic therapies. So I think very different landscape than it was not too long ago, when we didn't talk a lot about genetic testing unless there was someone in the family. So can you talk about genetic testing and what's recommended and genetic therapies, and do you see more genetic therapies coming down the road?
Obviously, we spoke about that new treatment for SOD1, which is just a fraction of the population of people that have ALS. The hope is that we will find other therapies for other genes that are not SOD1. It's complicated, and there's already some early successes, including with Dr. Oscarson here in the Mayo Clinic for another gene. So the recommendation for everyone, and I feel very strongly that everyone should get tested for a genetic mutation, and certainly important not to just take the results of that and stick them in your pocket and try to figure it out on your own. Go back to your neurologist and get some counseling, because the interpretation of that testing can be complicated and it requires expertise. And the neurologist may even refer you to a genetic counselor, for example. But it's nuanced because it's cutting edge. The genetic therapy, I think, is really the most, I'm biased, but I think it's the most exciting new treatment option for ALS. And designer genetic therapies are a real thing, and that's happening. And Dr. Oscarson could talk about that as well. But it's a very exciting time. I definitely recommend genetic testing, and yeah, that's my long answer.
So what is genetic testing? So one is that you can test one gene, SOD1, single gene, one answer. But now there are panels, and the SOD1 is within a panel. There's different companies, but there are about 40 plus genes, maybe. And then the report of those genes sometimes is confusing, because it says, okay, is the cause is pathogenic? Sometimes it tells you it's negative, and sometimes it tells you I don't know, is uncertain significance. So the results also can be a little confusing. And then after that, there can be short reads or partial reading of the genome, or you can have a whole genome completely read, all the genes there. Obviously, if you test one gene and then underneath will be variants within that gene, which makes it complicated, then you can have a panel with different variants within that, or you can have partial genome analysis and whole genome analysis. It's a whole specialty in its own, and I think above, at least the capacity that we have as a neurologist to understand all the genes. But I think that's where the world is moving, understanding the genes and what a group of genes does to your defenses or not is where we're going. But again, we're trying to test everything that we have some understanding so we can implement therapies like tofersen or Qalsody. Maybe begin to learn that there might be other alternative genes so we can quickly get you to that, even though it may be a very rare gene, so there may be some therapies coming around. But also to help science to understand what these genes mean. But you got to be careful because it's a massive amount of information, and when it's misanalyzed, it can have unintended consequences. So people need to understand the anxieties and the risks that you have having a gene. You don't know what's going to happen with insurance. So I think there has to be a lot of pre-genetic testing counseling, so you know what you're doing before you actually go and get the testing. But in general, in terms, at least for the general panels, we definitely want to make sure that the person does have or not an SOD1 because there's an approved therapy. That's a given. And for the other ones, I think some of them, like the C9, has a lot of prognostic value. So I think most people will try to get that one at least. But we test them all, and we test it on everybody.
And I will say something. So I think we're understanding maybe 15% or so of all ALS from single gene explanations. We think that there's going to be maybe another 35% or so that we're going to be able to see several genes interacting, leading to ALS. So there's still more for us there to understand. The ones we can treat today, and that's particularly that SOD1, but a couple of other ones, we have this new class of gene-stopping drugs. So it's where the gene makes something bad, and we can shut it down, and people do better. Many gene defects are actually where there's something missing. And we can't really fix that yet, but those kind of gene replacement, boosting strategies are in the works. They're harder to do for us today. And then there's CRISPR, gene editing, that some are working on, particularly, say, for that C9, since that's the biggest one. If we can just actually pick out a bad piece of the genome, that should solve it. Maybe not just for that person, possibly for their offspring too. So I mean, we're working on it.
Thank you for mentioning genetic counseling. That is a very important piece of the equation. Just take a minute and see if, Dr. Tahiti, did you want to say something? Okay. Questions from the floor? Any other questions? If not, I'll keep going. Okay, we have a couple of questions on clinical trials. So there was questions about the Unicure, so spelled UNIQURE, clinical trial for people with SOD1 on AMT 162. It's a very specific question.
This is another way of trying to tackle the SOD1 gene problem. We are a site for that study, but we're not really looking for volunteers from the US. We were looking for volunteers from other countries where we did not have access for a tofersen. For them, this seems like a reasonable choice. However, at this point in time, we're not looking for volunteers. It is a study that builds off work done by Dr. Brown up at UMass a few years ago. And that early development was troubled by a certain type of toxicity called dorsal root ganglia toxicity. So that was noted in the published literature before this project started. And yeah, I think that's all I can say. So it's not something that we're looking for volunteers for right now. Interesting idea.
And And then we have symptom management questions. So we understand ALS affects the nerves and the ability to move, walk, speak, swallow, and breathe. How is the bladder affected? Do people ever experience sexual dysfunction, such as erectile dysfunction? Or how does that play into someone's experience with ALS?
By ALS. So bladder is not being affected by ALS. It's basically, its disease will spur the autonomic system, so bladder is not affected. However, when a patient is constantly sitting on a wheelchair or seat or doesn't move along, and there's a difficulty about hydration, so then the bladder problem also happens, secondary to not getting enough hydration, infections, possibility of kidney stones, and then autonomic system also, their cycles are messed up because of the activities affected. So it's not a direct cause of disease. So that's why it's not basically it's a direct treatment for that. So it's basically when a patient had a bladder problem, it's something that a urologist would be the best way to deal with that and find out if it's an infection, if it's an stenosis, if it's an what kind of problem is that, and based on that symptomatically or basically treat the problem.
I would add that for people that have an upper motor neuron predominant form of ALS, like PLS, the extreme form, you can have a neurogenic bladder. I'm not sure if anyone here has seen that, but that's treatable. Probably because the frontal lobe has the micturition center, and that can be affected if you have an upper motor neuron predominant form. So, but I do agree otherwise, what you were saying.
Okay, we have about 5 minutes left before we go to our closing questions and our closing remarks. So last call for questions from the floor. And let me ask the panel, what are your thoughts about a triggering event for the onset of ALS? We had someone who submitted a question saying they had 2 mini strokes within 4 months before the onset of their disease, and the mini strokes did not result in paralysis. But what are your thoughts on triggering the onset of ALS?
Well, they're figuring out who's going to answer. I want to tag in on that on a very nice study that one of our collaborators in the National History Consortium looked at, that sort of question of triggering. And they took out the PROACT database, and they looked at the incidence of falls and what happened to the ALS-FRS score before and after falls. And they found when they looked at that, there was a slight increase in the decline in their disease after a fall, which when you talk about triggering events, that gets me to the point of we're always hammering about fall prevention. And there is now data that says what we've been talking about is very important in slowing this disease, that preventing falls. So maybe that's not triggering the disease, but certainly over the course of the disease, it's absolutely critical.
I know we all here have heard stories of patients who correlate with the onset of their symptoms after a fall, after a surgery, after some type of neurological event. I think it's hard to say in retrospect, was the fall the trigger for the ALS, or had they developed some subtle weakness that led to the fall? Was the surgery the trigger for the ALS, or did the surgery maybe not need to happen and the ALS had already started? So, tough question.
I just listened to a lecture from Dr. Adjalari on the discussions of what is the cause of ALS? Is it genetic or is it environmental? Something triggering from the outside, or if it's genetic. And they have, sometimes for fun, they discuss one and defend the other, so on and so forth. But he came with a very, very good explanation. So in genetics, most of the genes that we have come from our parents. So he gave an explanation, for example, on people's height. So if your parents are tall, it's likely that children will be tall because their parents are. But it's not, if there's a one gene, tall or high, so then it will, for example, some flowers come one color or the others. If you have that gene, it's white. If you don't have the gene, it's color. So it's one gene explaining the problem, and the environment has zero. So if you have the gene, that's the color. If you don't, so it's 100% genetic. It's not the case of ALS. These are many genes that they're part of the risk that you may have or the height you're gonna have. But if you put two brothers exactly the same genes, so they have the same risk for height, to being tall or short, but some of them grow in an environment with a lot of food where they're growing, and the other is growing in a place that there's not enough food. One is going to be taller than the other because the environment had different impact on those same genes. The same thing is with toxic exposures. So instead of just one fall or one exposure, usually is the accumulation of small amounts and living in an environment that are toxic. So, and then in addition to that, you have to have genes that are protecting you or genes that are not, put you at higher risk. So the combination of the genes and the kind of life exposure to something, including aging, is the ultimate thing. I personally think that is when something happens, is due to. So it's very easy to link the two events, but usually one single thing or two strokes, that's not really the event. It's most of the time it's coincidental rather than causative.
And I don't know that we really called out the National ALS Registry in any of our presentations yet today. So again, if you have questions about why, environmental factors, falls, injuries, register with the National Registry. That's our best US effort to try to sort this out. There's not clear connections that we have today, but we're trying to understand the whys of why ALS occurs.
And also register with University of Miami Capture Study.
Okay, to close our panel discussion, we have a question to ask each of the panelists. So Jerica, I'm going to start with you, and I'm going to ask you to answer, if you could change one thing about how ALS care is delivered today, what would it be?
Sure. So, I think that probably what we do in the clinic is, it's absolutely very important, but we're only capturing a fraction of the care that a patient with ALS has. And I think that the biggest impacts that we could have would be the improvement in home-based care. So access to cost-effective, high-quality home nursing care, and also probably, in addition to that, having access to skilled nursing facilities that have the appropriate equipment and training to manage an ALS patient effectively. And I think that if efforts were targeted in that direction, it would probably have the greatest positive impact on the ALS experience, short of a cure.
Great answer. I see a lot of heads nodding. Yes, we can give that a round of applause. Dr. Tahiti, what do we need to do better as clinicians, researchers, as a community to improve outcomes in ALS?
So this is a very broad question. It depends on who asks, who responds, and exactly what setting is that. So let me just kind of cut it to its in a more practical way that something will apply to only our clinic and our patients. So let's start from the patient side. So the patient side, I think that's something is very important, is being mindfulness. And patients should understand themselves, understand their weak points, what they are. And then they should know what it has been getting to. What's the disease is that? And try to learn from that. And of course, a lot of those mentions that it's what you're doing. The mere coming here, sitting, and that's what you're trying to do. And then, very important, show up, like in these meetings, and having a voice, because that will make a great difference to get the funds, get the attention, get the people work for that. And then also important, having hope. and persistently looking for that. And this is kind of has a feedback effect. So when the patient has hope, the people who take care of for the patient also try kind of provide for that. And then something probably, I mean, usually people don't talk about is donations. Donations is the reason that there's a lot of these ALS clinics exist. If there is no donation from the patients, families, people around them, and people are concerned for them, those clinics doesn't exist. That's very important. And then from the point of the clinician point of view, so we're trying to be as much as possible to be updated, medical knowledge, as much as everything comes, the new studies. And then the more important one is commitment. I mean, everybody in the job has dreams that everything would be ready, get great personnel. That doesn't happen. There's always limitations, administrations, funding issues. So I try, every of our colleagues fight every day to make the clinic running, to get the necessities, to get the staff. And even for some small needs of the patients, these are not small because the patients are in need. So, and we don't see it as a small, and we try our best. It's not always we succeed, but it's a fight along. And then as a researcher, it's basically, the research is future. It's something, see what would be in the future. And I see it as a duty, it's not a privilege. And I'm sure every of our colleagues that they put all their mind and effort is that they should have the duty to push forward these boundaries and to overcome the gaps that we have. So overall, it's basically all this, whatever you heard from our colleagues and what's been going on, it goes to that questions piece by piece. But I just tried to put it in a framework.
Thank you. Dr. Weimer, what's the greatest change for the positive that you've seen, the greatest improvement that you've seen over the last 5 years?
So to answer that, I guess I had two, but I'm going to throw in a third one because, well, I'll come back to that third one first. But the first one is what you've seen up here. And I think the positive collaboration that we all have between centers is something that I think I've mentioned this before at previous talks, that I've practiced elsewhere in the country, and I haven't seen as much collaboration as we have here not just at the physician level, but at all levels, be it the nutritionists, the geneticists, the nurse practitioners that are all communicating to develop the best protocols across the state. That I think Florida stands as a very unique place in terms of that. That is just drives us as clinicians to do more because we're getting the staff to do that. And so I think that's one of the huge, and also, of course, is a huge part in bringing us all together for that. So that is a big positive that I've seen. The other, and it's a little bit of an advertisement for some of the other centers because they played a key role of it, is I want to get back to that. And patients have asked me what's been the biggest change, and this is what I've talked about. If you look at that the most recent SOD data of which you saw out there, okay? Now, granted, this is a small subset of patients, okay? This is what, 2-5% of the total ALS population that may get this, that will actually have this. But when you give them that treatment, there is a subset within that group that had rapidly progressive disease, and it plateaued or got better. And to me, that tells me as a researcher, if we can work harder to figure out that cause at the front end, this is a disease we can do something about. So that kink in the armor is what we were looking for when we all met however many years ago and started some of these consortia to try and develop that together. And we're starting to see that kink. And I think that's one of the things that is just really exciting to me, that now, and you heard all of the researchers, we've got our projects trying to figure out what is that first line event we talked about genetics, genetics, genetics. It's not genetics. It's because it's genetics, it's environment, it's all of this put together. It's who the person is, and it's working through those things where AI can help. But if we can figure out those factors and we can identify those factors, we've got data that says we can really impact this disease. So that's the really big positive thing that I think has come out that excites me. And you got to figure what gets you up in the morning to come in. It's the chance to do that. And the third thing is you guys. I mean, we see a lot of absolutely wonderful people, and that positiveness of seeing all of you when we come in and see you in clinic is also what has, and your enthusiasm, and that's something that has grown. Patients that are just interested in, well, what can I do? How can I help? Where can we go? What's the next step? I've got several of them, and they know who are here in the audience that on a routine basis yell at me, what are you gonna do next? What are you gonna do next? What's the next trial? And that's what we love. That's been very positive. And those patients know who they are.
Thank you. So, Dr. Oscarson, I asked Dr. Weimer about the last 5 years and what's gotten better. What do you want to see looking ahead 5 years? What advancements would you most like to see in the field of ALS?
So you've heard about effective targeted treatments for one form of ALS today a couple of times. I would like to see that for all in 5 years. I think there's some attempts aiming at that TDP-43 that could work, and we could have readouts and sort of even an approval within 5 years. So if my dreams come true, everybody pretty much with SOD1, FUS, CHTG10, and the large portion of people with TDP-43 ALS would have a targeted effective treatment. It is possible, and I'm absolutely hoping for it.
Dr. Locatelli, what's the most important message that you want people living with ALS, caregivers, and families to take away from this panel discussion today?
So thank you, Dr. Weimer. You talk all the things I was going to say.
I planned it that way.
So, because it's, but I'm going to try to build on that a little bit, because what you mentioned is how this group of neurologists collaborate, and that truly is the feeling. And you were the only one that you got late to the meeting at noon, but that was the topic of noon. It was, we created a Florida consortium last year. We shared our phone numbers and our emails, and throughout the year, we really all felt that when we needed help, we reach out. Everybody answered, everybody helped. We transferred a patient, we referred for a study. We did all that behind the scenes. And I think it was a remarkable thing to see this year with a couple of new people coming on board. And I said, okay, this consortium, call us, we'll be there for you. And that is something that this panel here, we had about a couple hour meeting earlier today. We really becomes friends. We trust each other with the things that we know. Some centers have more than the other center, and we refer. And so it's been an amazing group of people supporting us to put you at the center so we can send you to the best place to get the need to have what you need out there. I want to tell you though that the ALS community, in terms of what Jim was saying about the patient, is a very strong community, not only in Florida. The ALS Association doing an amazing job here in Florida and in the country. Is not the only association. I did a trip recently, and I have seen this, that now internationally, these patient communities are getting together. The associations are getting together. And the community are having bodies internationally. There's an international alliance, which used to be Europe and the United States. Then in the last 15 years, Australia has become very strong, and the whole Pacific area with Japan and China are having a consortium. And then added Latin America, it's called ELATAM, has now a very robust alliance that is building up sites in other parts of the world. And actually, the African community also got together and through the International Alliance Forum. So now the whole world is represented in different sections, is integrated by International Alliance, and you can see that it's not only the research community getting together to collaborate, like we did today here, but the patients are also learning from each other through efforts to collaborate and philanthropic efforts on communities to create awareness, to actually push their governments to approve the therapies, to approve more therapies at home and nursing at home and all of this. So the movement has been now integrated. And it's not everywhere is the same, but everybody's learning from everybody's and the different geographic areas, cultures, ethnicity. So we really need this now international community to solve this problem. So what you see here today, which it was beautiful for me to live today in the meeting and knowing that I can trust in local colleagues, but I know there's a bigger community that we can also reach out and send everybody to the right place and trying to get the best science to your family anytime that is required. So I'm very hopeful for all of that development.
Great. Dr. Carberry, one of the things I've noticed is people who start researching ALS don't stop. They stay in the field for a long time, and they just keep working at it. So I'm curious how you would answer, what keeps you motivated to do this work?
Boy, it's hard to follow everyone else here. So ALS is a horrible, horrible disease. I'm completely impassioned by my patients. I'm impassioned by my patient's family. I'm impassioned by my colleagues for all the reasons that everyone here has said. The field really does attract very smart, very compassionate, high emotional intelligence people. And so it's very easy to get along with these folks. So that's what really drives me. I love my job, I really do. And I am convinced, just with the early success, early for me, I know you all have been waiting longer, with the SOD1, I'm very convinced that we'll have continued success. And I think the most important thing is just showing up. You all showed up today, we showed up, and we're gonna keep showing up until we solve this.
And Dr. Ula, what gives you hope right now that ALS will become a livable disease?
I think everything that we've heard and we've seen today and all of the efforts with regards to research and collaboration and trying to understand science, the genetics, and how we can target it. But apart from that, it's also the solidarity of the ALS community among researchers, clinicians, the multidisciplinary teams, caregivers, and patients. I think that that determination, it's a powerful thing. And although we don't have all the answers right now, I think we're all definitely moving forward.
Well, I'd like to extend a very heartfelt thank you to our panel today. We just have so much admiration and respect and love for all of you up here. You are our hometown heroes. And thank you so much for coming to the conference and for answering questions and sharing your hope with us today.